Carolyn. I'll try to be brief and as much as I can. This is about empiric antibiotic therapy for neonatal sepsis, not starting drugs for the very low birth weight baby, not treating bacteremia, what do you do with that, but the babies that for whom antibiotics are started for whatever reason, and then cultures maybe don't come back positive or an infection isn't confirmed, and we often continue therapy empirically for variable periods of time. And the question is, how much is enough? And this is an area ripe for discussion. I think that, as I see it, there are discussions about 2 days versus 5 days versus 7 days versus 10 days, even 14 days. So how is a clinician supposed to sort this out? Well, it would be fantastic if we had lots of randomized controlled trials looking at 2 days versus 5 versus 7 versus 10. That would be great. Is there something to be learned from how long we typically treat known infection, like group B strep for 10 days of bacteremia or pneumonia for 4 to 7 days? I don't think there's a lot to be learned from that, except that we shouldn't treat empirically longer than we would treat for definitive infection. I think that's fair. So I'll not follow up on that anymore. And then I want to share with you some stewardship data. When people made changes on the duration of empiric therapy and what happened when they did that. And then, of course, there are guidelines and expert opinion. And let's just remind ourselves of what those are. And here are right from the AAP Committee on the Neonatal and the COID guideline for term babies or greater than 35 weeks. I'm not going to read all these words to you. The purple ones are the ones that matter, that, as you know, generally recommended to discontinue if cultures are negative at 36 to 48 hours. And then for preterms at less than 35, it's the same thing. And I think they made a point to add this particular little caveat: very low birth weight babies in and of itself, that factor is not alone an indication for prolonged drug. Okay, whoops, this is moving without my permission. So I apologize for that. All right, do we adhere to stewardship guidelines? So let's just think about that for a second. Vaughn, all of you know the Vermont, this thing is moving ahead of me without my permission. It's annoying. Anyway, so Vaughn, you all know what Vaughn is. They looked at 142 of their units as sort of a point prevalence, a point assessment a few years ago. And they tried to assess whether centers had elements from the CDC core antimicrobial stewardship elements and how many of them they had. And I'm only going to report a couple of them. Only 6%, and this is only a few years ago, had an internal NICU system to report stewardship progress or drug use. And only 15% at the time reported even tracking it. This is Vaughan, through Vaughan nationally. And the NICU level didn't matter, level 2, 3, 4. So there's that information. At the time, 13% of these babies were treated but didn't have a blood culture sent first, which is the thing you'd like to do. And we get that sometimes there are time constraints, but this is just what the data showed. So this is just sort of a summary, and I don't want to talk about that right now. So the next slide is, what is the distribution of practice within our group? And Joe presented this a little bit before, so I'm not going to present all that data. Just two key pieces as it relates to empiric use. So there's what he found with his group, wide variation in drug use, just all over the map. I think nobody is surprised. And the median was 25% of babies, but it ranged from essentially 0 to essentially all of them. So there's quite the distribution. And all of this was independent of confirmed infection, NEC, surgical volume, mortality, some of the things that might drive use. And it didn't correlate with actual positive cultures. And again, we've heard that a little bit in these sessions. Where are the opportunities for stewardship? Real quick. Well, lots of data from various places. Generally, around half of all drug use in the NICU is related to rule out sepsis. A good quarter is culture negative sepsis. This is the empirical use we're talking about. And empirical use more than 5 days was a quarter of all use in one of the largest studies. Pneumonia, a chunk, and NEC, a chunk. So there are, again, no one on this call is, everyone knows that there are opportunities for stewardship. So let's talk about stewardship trials, okay? So I'm going to show you a bunch of data. This was in Greece. They just went after what they called low-hanging fruit. Nearly all the public NICUs, term babies, mostly section, mostly not choreo, and mostly not rupture membranes. These are low-risk babies. Please, they said, don't treat empirically for more than 5 days, and this was their result. A significant decrease in the proportion of babies that were treated for 5 days. And I only show this to you to suggest that in Greece and public hospitals with low-risk babies, it was pretty easy to do. And the mean length of stay went down 1 to 3 days, depending on the NICU. Okay. Now this was at Parkland in Texas, 2,500 infants, kind of the Scout study, the biggest, most sort of, famous study, I think, in this country. What did they do? They had a 48-hour hard stop for early onset rule out sepsis. And then they suggested to people, please don't treat pneumonia for more than 5 days and culture negative empiric sepsis for 5 days. Now they wanted to do 2, but they didn't think they could implement that sort of readily. So they compromised at 5. And this is the beginning of where 5 became a bit of a thing among neonatologists. It preceded this, but this is, I think, in some way where it was codified because it was published in the Lancet Infectious Disease, very prominent journal. And basically they found that their 48-hour thing really happened. It went from 32% to 95%, okay? Pneumonia treatment for 5 days or less went from 36% to 72%, and that means these were all being treated longer in the past. Culture negative sepsis, the empiric, how long to treat, well, they went from 31% under 5 days to double it, 62%. Now, not everybody went under 5 days, but they had a significant improvement with a hard stop again and a recommendation to stop at 5 days. So it's doable. And there were no bad outcomes down here. That's what this is. No infant required additional drugs. The number and proportion of types of cases didn't change, etc. Okay. This is just a bunch of studies. I'm not going to go over all the details, but a bunch of studies. Can less prolonged therapy be accomplished? Can it be done? NICU. Decrease in duration of therapy in all of these studies is shown here. The blue is before they did something, and the pink is after they did something. And the y-axis is days of therapy. Bunch of studies, and I just list for you what they did. There's some hard stops. There's some sort of education, some algorithm, a lot of different options. The point is that every single one of these studies showed statistically and clinically significant decreases in the duration of therapy. So it's very doable with certain interventions. What about antibiotics greater than 48 hours? Can that be accomplished easily? Well, I showed you some data already. Here are some more. Again, blue is pre, pink is post. This is percent of babies who got less than 48 hours, and it goes straight down in all of these studies. So I think most of you know that it can be done, but I wanted to get us all on the same playing field on the kinds of data that are out there and the different types of interventions that make it happen. Let's skip that one. Now, what about very low birth weight? Higher risk. These guys did a hard stop at 36 to 48 hours, trying to stop the prolonged empiric use. No other intervention, okay? So 2010, 11, 12, 13, and you can see the change in days of therapy over here from roughly 7 to 8, and then suddenly it's down to 4-ish. So they didn't get everyone to stop at 2 days. This is very low birth weight babies. And if they were treated, these babies, the percent that got drug beyond 2 days went from 88 to 64%. Again, very low birth weight babies, highest risk, or higher risk. I guess extremely low birth weight is even higher. What about late onset sepsis and just vancomycin? This was at Hopkins, very well done study over several years. Here's baseline, intervention, and continuation. They did various things, but the hard stop was really the main push here. And you can see the therapy per 1,000 patient days just sunk like a rock by 2/3. This is late onset sepsis, vancomycin only, and there was no change in gram-positive, disease rates. This is for late onset sepsis. And for NEC, same thing, vancomycin for NEC, which is its own discussion, but nonetheless dropped like a rock, almost 90% decrease and no change in gram-positive disease rates. at Hopkins. Okay, same study. This is AKI likelihood. Suddenly, when you stop all that vanc use, you don't see AKI. This is not news to people. I mean, you know, vanc causes AKI, but it's doable in a big, huge academic, tertiary, quaternary care NICU setting, just to say, and just to show you this information. Okay, so I want to say that in no NICU stewardship study was there a rise in clinical morbidity or mortality post-implementation. That is our fear, and that's a real fear. And it's not suggesting that we do all of these things for every baby, but for in a controlled circumstance for selected babies, it can be done safely. What about, are there any randomized controlled trials or cohort studies? And I'll tell you, to show my cards first on this topic, there really is not a fantastic evidence base that directly looked at 2 versus 5 versus 7 versus whatever. They just hardly exist. The few data that are available, pilot study randomized for sepsis. These are, you know, young to older babies. 2 to 4 days, that is when the culture comes back negative, or 7 days, stop your drug. No difference in treatment failure. Now it's a small study. It's a pilot study. There were 26 babies each. That's too small, but that's what it is. This was the same kind of study, a little bigger, for respiratory distress patients. Not necessarily rule out sepsis, but basically. And then they got better in 2 days, and these were term babies. 4 versus 7 days, no difference. Now, small study, not definitive, but this is the state of the art for the randomized trials on this concept. What about cohort studies? Extremely low birth weight babies. This is just almost 700 culture negative babies, and the distribution by week at that, in this setting, with the same mortality, morbidity, maternal risk, crib scores the first hour of life. I only share these data to show you that there's great, it's pretty much equal, less than 3 days, 4 to 6 days, 35 days. And what drove this wasn't necessarily the clinical issue of some overwhelming sepsis ongoing. Look at very low birth weight babies, similar thing. 60% got 3 days, 10% got 4 to 5, the rest got greater than 5. And if you're on a vent, you tended to get more, which makes sense at high levels. I share these cohort data to give you some sense of the distribution, but in both studies, I should say the first study rather, this is what drove change, or didn't drive change, I should say. The initial antibiotic course duration by week of gestational age went down once you got older to 3 or 4 days. Here you're 4 or 5 days, and at less than 26 weeks, you're 7 or 8 days, independent of clinical issues. And this is human behavior, and this is what it is for very low birth weights. And I showed you previous data that you can successfully do stewardship with very low birth weight babies without overt harm. So the last 2 slides are the negative impacts. And Linda actually sent me this study, ironically, today. It's actually on our reference list in the box site. In Canada, they looked at almost 3,000 infants. These are very low birth weight babies only. Regression analyses controlling for a lot of things that matter. And they claim that prolonged antibiotics in the first week of life, and we've talked about this a little bit, increases the likelihood of death, chronic lung disease, echogenicity in the brain, or retina, ROP. And their main outcome was all of them combined. It's an 18% increase. It's not a perfect, it's not the answer, but it is taken in conjunction with other data suggests that giving antibiotics independently causes bad things. And the question, of course, is, do you give antibiotics and you screw up the microbiome, which has a significant impact on the gut-associated lymph system, which then leads to systemic inflammation to cause all these things we just noted? Or are sicker babies getting antibiotics, which they clearly are, and you're making the wrong conclusion? I dare say we don't know for sure, but I will tell you the data seem to be accumulating that it's a bit of both, but there clearly is some impact of broad spectrum antibiotics, particularly on the VLBWs and the extremely low birth weight babies, in causing secondary effects up to and including neck, death, and the other things that I mentioned. So the last slide I have, what can we here in our group further lessen empiric use? Well, stopping drug, as opposed to starting, is the most visible goal now. We've spent some time on starting drug. We'll continue to spend time on starting drug. But nationally and elsewhere, and I think amongst ourselves, stopping empiric use, duration of therapy, is the most visible and obvious target. And there's tons of practice variation. Whether you're looking at Joe Schulman's data or some of the other data I showed you as to what's going on nationally, it's very clear that there's a lot of variation in every age group. Normal birth weight, very low birth weight, extremely low birth weight, much of which is not driven, at least in our capacity to detect overt clinical detection, overt clinical markers for that. Just to note that the US, and I didn't show you, but the UK guidelines are harmonized to stop drug at all possible for these rule-out sepsis babies at 2 days. There are very few randomized controlled data that I shared them with you, that's it. But this, in my view, the stewardship data are compelling. And the stewardship data come from several methods: randomized data, cohort data, quasi-experimental, which is basically then versus now. And for me, that's validating that regardless of how you look at it, it works, and it can work. And oh, by the way, it's been studied in early onset, late onset babies, sepsis, and every age group that you care to think about. And really no evident bad outcomes when you pick and choose appropriately. And that greater than 2 day therapy, I shared with you the Ting data, may lead to some bad outcomes. And there are just more and more data coming out on that all the time, but it remains to be fully fleshed out. So I think for me, the big message in this talk, which I'm ending, is to try to get us all on the same page about the variation in practice, what drives practice a little bit. Can we be successful if we put our minds to it? And it takes more than just putting our minds to it. It's all the things we've been talking about, whether it's a team, whether it's a champion, whether it's rounding, whether it's timeouts, whether it's hard stops, whatever it might be, or some combination. You can succeed in every birth weight, in every setting. And to keep in mind that, if we continue to use prolonged antibiotics when they're unnecessary, we may be starting a process of systemic inflammation that causes bad things that we would never have predicted otherwise. So I think that's my 10 minutes. So I'm going to stop there.